The first is for Dr. Gomez. I don't know if she's on. There she is.
Okay.
I am.
Okay. And it's aren't ABPM subject to the same oscillometric flaws? So I presume the meaning is as in adults, but I could be wrong.
They are. The difference is typically what we do is we specifically bring kids in to fit them for an oscillometric, like for the ambulatory blood pressure monitor, and compare it to a series of manual blood pressure readings in clinic to make sure that we're able to get something that correlates or to understand how exactly it differs. So it is subject to some of those same flaws, but we do at least bring them into clinic to make sure that it correlates as much as possible. And I do think that's an important step to doing that if you're going to do an ambulatory blood pressure monitor.
Perfect. And then for Anna Nuchik-Whitford, for question 4 regarding Alport syndrome, why can't the answer be A, XLAS carrier state? I don't know the question, so.
Let me go back and check. Give me a second. Oh, great. That's a really good question, actually, and that's the trick here. So her father had ESKD at 45, and so since she obligatory has to inherit an X chromosome for the dad, right? Because she didn't inherit the Y chromosome. We would expect that the dad, if he has the same disease, right, and he SKD, he would be expected to have a severe form of Alport. And so usually we would see, especially in someone who didn't have a diagnosis of Alport and wasn't treated, and was a heavy smoker, we would probably see ESKD onset much earlier than 45. So that was the trick there, and that's why, I put that. It's Alport is tough, but that was a really good question.
Curveball. Okay. And then last question for you, Anna. As far as you know, do genetic testing labs keep patient data in case a finding of undetermined significance can be classified as pathologic in the future with advances in knowledge? In a related note, do you encounter patients who insist on repeated genetic testing in case new data has materialized over time?
So both questions are excellent. The first question is, yes, in general, the labs do keep track of the data they've generated. Of course, it varies lab by lab how long, and it, hopefully the lab doesn't go bankrupt, as has happened, unfortunately, to some of the labs historically. But yes, and I feel like many of them do try to reclassify the variants, especially if, this pops up in a later evaluation, they go back, they check. We have received updates from different testing labs with new classifications. So that does happen. But to the point of this person's second question, we are, I think we're heading towards the approach of oncology, where there's so much new data that comes out every few years in terms of discovery. And of course, we in nephrology are like decade behind when it comes to clinical genetic testing. But there is this approach of retesting patients every 5 years if there's not a definitive cause. And so that's been a little bit advocated, especially by the genetic counselor that works with me, who also works in oncology, because that way you take the responsibility towards us of, kind of rechecking this rather than just relying on the lab, doing this and updating us. Those are really good questions.
Absolutely. And then the rest are for John. So is maintenance, this is a good question, is maintenance therapy needed in hydralazine-induced RPGN, even if hydralazine has been discontinued?
That's been a little bit of a controversy. There certainly have been some relapses and late relapses in hydralazine-induced patients. Overall, there seems to be less relapses from hydralazine, but it's not zero. And with PTU, for instance, we've seen lots of late relapses with some of the PTU patients. So I think the answer is yes, maintenance is needed, but perhaps can be stretched a little bit longer if there's a good response with the antibodies.
All right. The next question is, have you given rituximab maintenance for greater than 5 years?
We have. We do it by allowing B cells to recover between doses. And so initially we like to see a few B cells before the next dose. And later on, we like to see them reaching normal levels before giving the next dose. There's very few relapses the first year after a dose of Rituxan, but there's a lot of relapses in years 2, 3, 4, 5. And so so we keep going a long time.
And I have a question. So if you get a serological relapse, somebody's following along, they have no symptoms, how do you treat that? Do you just resume the rituximab?
Yes, we will resume the rituximab, and we have some data that you can follow the ANCA and try to do it that way and hold off treatment. But most ANCAs, most serologic relapses are found at the same time as the clinical relapse. So you don't really get ahead of the game very far in most cases.
Perfect. And then the next one is, are there data for obinutuzumab and ANCA-associated disease relapse?
There's no data or no more than anecdotal data at this point. Rituximab works very well. Obinutuzumab, I'm sure, works very well. But so I think either drug is fine.
And then the last question for you is, in your protocol, do you always use PO Cytoxan?
Pulse IV Cytoxan is equally good. Most of the British groups use it. We use the PO mostly for logistical reasons. It's just been harder to get the quick turnaround of IV cyclophosphamide. So that's why we use PO. It's very well absorbed. It can be done as PO Pulse or as PO daily, either way. So any of those options work, whatever works easiest from your practice.
And then these are pouring in to check B cell levels. What test do you order?
We order the anti-CD19, lymphocyte subsets. It's been a challenge with some labs. Mass General Brigham has now got a pretty smooth, but a lot of the outside, and so does Quest, but some of the other labs have more complicated testing, and if they're sent out to somewhere far away, you lose cell viability sometimes, and so they can be a bit challenging to get. But most places there's some way to get them, similar to the T cell ratios that we used to get all the time for HIV.
Yeah, a lot of community hospitals, you have to do a full flow cytometry to get a count. And then do you give maintenance rituximab for MPO ANCA vasculitis? If you do, is it shorter than PR3 ANCA?
In our hands, MPO vasculitis had almost the same relapse rate. There really isn't a big difference. Some trials have shown lower relapse rates. MPO ANCA vasculitis is a little more insidious. There's often more renal failure with it. So from a renal perspective, it's at least as dangerous as PR3. So yes, we do.
All right. Let me check for any more emerging. I don't think so. I think we're all done. Okay. Thank you. Wonderful talks. And we will see all the participants tomorrow. Thanks.